Welcome to the deep dive. Today we're going to really unpack a crucial group of medications for anyone heading into nursing.
That's right. We're talking about adrenergic blocking agents.
Sometimes called sympatholytic drugs, right?
Exactly. Sympatholytic beta.
Think of this deep dive as, your guide to really getting how these drugs work and what they do in the body. We've sifted through the material to pull out the key insights, especially for nursing students.
Yeah, absolutely. Because at their core, these agents, they interfere with the sympathetic nervous system.
The fight or flight system.
That's the one, fight or flight.
Mhm.
These drugs essentially stop hormones like norepinephrine and epinephrine from activating specific receptors.
Yeah.
So they block those stress responses.
And for nursing students, this is just fundamental stuff. You'll see these meds everywhere for so many different conditions.
Knowing how they work is just key for safe, effective care. Really is.
Definitely.
So to break it down, we'll cover the different types. First up, the non-selective ones, they hit a wider range of receptors. Then we'll look at alpha-selective blockers. Some are non-selective within the alphas, others specifically target alpha-1.
Got it. Alpha selective.
And finally, beta-selective blockers. Again, non-selective betas and the more targeted beta-1 selective types.
Okay, sounds like a plan. Let's start with those non-selective adrenergic blocking agents. What exactly makes them non-selective?
Simply put, they block both alpha and beta adrenergic receptors. They don't really distinguish between those two main types in the sympathetic nervous system.
So they're not picky. Why use something that blocks both? What's the main rationale?
Well, their main job, mostly treating heart-related conditions.
Heart conditions. Okay.
Yeah, because by blocking both alpha and beta receptors, right,
Both. Right.
they can have pretty significant widespread effects on things like heart rate, blood pressure, basically how the whole cardiovascular system is working.
Can you give us a few key examples, the ones we're most likely to see?
Sure. The big ones are amiodarone, carvedilol, and labetalol. You'll definitely encounter those.
Amiodarone, carvedilol, labetalol.
Got it. Okay, so what do they do? What are the main physiological effects?
Okay, so basically, these drugs compete with norepinephrine. They stop it from binding to both alpha and beta receptors all over the body.
Like stealing its parking spot.
Exactly. Good analogy. It blocks norepinephrine's effect. And this widespread block leads to a few key outcomes. Blood pressure tends to drop.
Lower BP.
The heart rate slows down.
Slower pulse.
And interestingly, you often get improved blood flow to the kidneys and also less renin production. Renin is another hormone that pushes blood pressure up.
Ah, so decreased renin levels too. Makes sense. Now, let's get specific. When would we use, say, labetalol? Labetalol is quite versatile, comes in IV and oral forms.
Oh, okay.
Its main gig is treating hypertension, high blood pressure. It's also really useful for hypertension linked to pheochromocytoma.
That adrenal gland tumor, right?
That's the one. And also for managing those blood pressure surges that can happen when someone suddenly stops taking clonidine.
Okay. And amiodarone. I feel like I hear that one in more critical care setting.
You're right, you often do. Amiodarone, also oral and IV, is crucial for life-threatening ventricular arrhythmias. Think VFib, VTach.
Serious stuff.
Very serious. And also for atrial fibrillation. Now, it's technically an antiarrhythmic, but it does more. It blocks sodium channels, it has those beta-blocking effects we're talking about, and it has a negative chronotropic effect.
Meaning it slows the heart rate?
Precisely. Slows the actual rate of the heartbeat. So it's working on multiple levels to stabilize things.
Multi-action. Okay. And carvedilol.
Carvedilol is oral only, used for hypertension and heart failure. It's also really helpful for patients post-heart attack, post-MI, who have ongoing left ventricular dysfunction.
All right. So we know what they do when they're used.
Yeah.
How about pharmacokinetics? How does the body handle these non-selective blockers? Absorption, distribution?
Yeah, kinetics.
Yeah.
So generally, the oral forms are absorbed pretty well. Once in the bloodstream, they spread throughout the body, whether given PO or IV. The liver does most of the breakdown, the metabolism.
Liver metabolism.
And then they're eliminated in both feces and urine. One thing to note, though, is the half-life, how long it takes to clear half the drug, that can vary quite a bit depending on the specific drug and formulation.
Right. Half-life varies. Now, safety first. What are the big red flags, the contraindications? When should we absolutely not give these?
Okay, key contraindications.
Yeah.
Obviously, a known allergy. That's standard.
Yep.
Also, patients with severe bradycardia, a very slow heart rate, or certain heart blocks, the drug could make those worse.
Makes sense.
And definitely avoid them in shock or heart failure that needs inotropic support drugs to strengthen the heart's pump. These blockers could weaken it further.
Right. Could worsen the failure.
Exactly. And finally, lactation. Breastfeeding is generally a no-go, especially with amiodarone, due to potential harm to the baby.
Okay, those are the hard stops. What about cautions? When do we need to be extra careful?
Good question. We need caution in diabetes. Big one.
Why diabetes?
Because these drugs can mask the usual warning signs of low blood sugar, hypoglycemia, and sometimes high blood sugar too. Makes it harder to spot and treat.
Oh, wow. That's critical for nurses.
Absolutely critical. Also, caution with asthma or other bronchospastic conditions. Blocking those sympathetic signals could trigger breathing problems.
Beta-2 blockade issue, right?
Precisely. And pregnancy.
Hmm.
Well, caution is urged. Data is limited for labetalol and carvedilol, but amiodarone is known to cross the placenta and can cause fetal issues, slow heart rate, thyroid problems, growth restriction.
So significant risks there.
Definitely significant. Benefit must clearly outweigh risk.
These are all really vital points. Okay, adverse effects. What kind of side effects might pop up with these non-selective agents?
Given they hit the whole sympathetic system, the list can be, well, broad.
I bet.
CNS-wise. Dizziness, maybe some tingling or paresthesia, insomnia, depression, fatigue, vertigo.
Okay, CNS effects.
GI issues, nausea, vomiting, diarrhea, maybe lost appetite, gas, kind of standard gut stuff sometimes. Cardiovascular. You can see arrhythmias, hypotension, worsening heart failure, pulmonary edema, even stroke in some cases.
Serious CV risks, too.
Yes. Respiratory, bronchospasm, cough, runny nose, worsening airway obstruction.
The breathing issues again?
Plus, decreased exercise tolerance, sometimes hypoglycemia, rashes. And crucially, you cannot stop these abruptly after long-term use.
Why not? What happens?
The rebound effect can lead to severe hypertension, MI, stroke, dangerous arrhythmias. Really dangerous.
Wow, okay, so tapering is essential.
Absolutely essential. And specific drugs have specific warnings, too. Carvedilol and labetalol carry a risk of liver failure.
Liver failure.
And amiodarone.
Right.
Well, it has a unique profile. We watch for liver injury, yes, but also pulmonary fibrosis, lung scarring, vision loss, and thyroid problems.
Amiodarone sounds like it needs careful monitoring.
Very careful. It's effective, but has serious potential downsides.
Okay, that's a lot. How about different age groups? Lifespan considerations, kids first.
Right, pediatrics. For many of these, safety and efficacy aren't fully established in kids under 18. If used, dose calculation is critical. Weight-based, age-based.
Double check the math.
Always double check. A second nurse verification is best practice. We do see proportions sometimes for hypertension or phentolamine for pheochromocytoma surgery, and there's a specific propranolol oral solution for infantile hemangiomas in babies.
Okay, specific uses, but always with close monitoring.
Always. Now, adults.
Adults.
Mostly being aware of that whole range of adverse effects we discussed.
Yeah.
Especially diabetics, they need re-education on glucose monitoring because those warning signs might be masked.
Right, the masking effect again.
Yeah. Severe thyroid disease, higher risk of serious side effects. Propranolol, metoprolol, and other beta blocker tend to have more CNS effects.
Okay.
And pregnancy and lactation generally, only if the benefit truly outweighs the fetal or infant risk. They can affect labor. Newborns might have issues. Breastfeeding usually not recommended.
Got it. And older adults.
Older adults are often more sensitive. Increased risk of CNS, CV, GI, respiratory side effects.
Oh, sensitive. Go.
And their kidney or liver function might be slower, so higher risk of drug building up to toxic levels. Start low, go slow, monitor closely. That's the mantra.
Start low, go slow. Good advice. Let's talk interactions. How do these non-selective blockers play with other drugs?
Interactions are definitely something to watch. Using them with volatile liquid general anesthetics can increase the risk of severe hypotension.
Anesthesia interaction.
They can boost the effect of some diabetic agents, increasing hypoglycemia risk.
Hypoglycemia again.
Carvedilol. With certain calcium channel blockers like verapamil or diltiazem that can cause heart conduction problems.
Conduction issues.
Amiodarone plus carvedilol can lead to dangerously high carvedilol levels. And amiodarone with other drugs that prolong the QT interval. That increases the risk of a nasty arrhythmia called torsade de pointe.
Torsades, right. Need to check those ECGs.
Absolutely. Care for medication reconciliation is key.
So, wrapping up non-selective blockers, from a nursing perspective, what's the game plan? Assessment, interventions.
Okay, nursing process. Assessment is huge. Check history for contraindications, get baseline vitals, assess cardiac, respiratory, GI systems, review labs.
The whole picture.
Exactly. Then nursing conclusions may be risk for decreased cardiac output, altered breathing, risk for injury from dizziness, diarrhea potential, Knowledge deficit.
Identifying the risks.
Right. Planning focuses on achieving the therapeutic goal, minimizing side effects, and ensuring patient understanding.
And interventions, what are we doing?
Key actions. Emphasize never stopping abruptly. Promote lifestyle changes. Monitor heart rate, BP. Check for orthostatic hypotension.
Checking that postural drop.
Yep. Institute safety measures for falls. Monitor GI function. Watch for signs of liver issues, especially with carvedilol, labetalol, amiodarone. Provide support, teaching. Document everything.
Thorough monitoring and teaching.
And evaluation, of course. Is the drug working? Any side effects? Does the patient understand? Are they adhering? Are they comfortable?
The full loop. Okay, great overview of the non-selective adrenergic blockers. Let's shift now to the non-selective alpha-adrenergic blocking agents. What defines this group?
Okay, non-selective alpha blockers. These have a specific affinity, a preference for alpha receptor sites, but their use is actually pretty limited now.
Why limited?
We generally have safer, more selective options available these days.
Okay. Is there one key drug we should still know in this category?
Yes. The main one you might still encounter is phentolamine.
Phentolamine. All right. How does it work? Its actions.
Phentolamine blocks postsynaptic alpha-1 receptors. That causes vasodilation, lowers blood pressure.
Lowers BP.
But interestingly, it also blocks presynaptic alpha-2 receptors.
And what does blocking alpha-2?
Alpha-2 usually acts like a brake on norepinephrine release. So blocking it can actually lead to more norepinephrine release, causing reflex tachycardia, a faster heart rate, which can sometimes happen when BP drops.
Ah, so it can cause tachycardia. Okay. When do we use phentolamine?
Its most common, and maybe most important use, is to prevent tissue damage if an IV infusion of norepinephrine or dopamine leaks out. Extravasation.
5E extravasation rescue.
Exactly. It causes vasodilation in that area, restoring blood flow, preventing tissue death. It's also used for severe hypertensive reactions during pheochromocytoma surgery or diagnosis.
Pheochromocytoma again.
Yep. And there's even a specific formulation used to reverse numbness after dental procedures that used local anesthetics with vasoconstrictors.
Interesting. How about its pharmacokinetics? How's it given? Cleared?
It's absorbed fast after IV or IM injection, primarily excreted in the urine. Details on metabolism and distribution are a bit limited, though.
Okay. Contraindications and cautions for phentolamine.
Contraindicated with known allergy, of course. Also generally avoided in patients with coronary artery disease or a history of MI, as it could potentially make things worse.
Worsen heart conditions.
Right. And caution is needed in pregnancy and lactation due to potential risks.
And side effects. What might we see?
Often related to its main action, too much vasodilation. So hypotension, orthostatic hypotension.
Low blood pressure.
Angina, MI, stroke, flushing, tachycardia, arrhythmias. All linked to the drop in BP or the reflex effects.
Okay.
You might also see headache, weakness, dizziness, again, likely due to low BP. And some GI upset like nausea, vomiting, diarrhea is possible.
Any major drug interactions with phentolamine?
Yes. Drugs like ephedrine or epinephrine, which raise BP, won't work as well because phentolamine does the opposite.
Counteracts them.
Right. And combining it with alcohol, another vasodilator, could increase the risk of severe hypotension.
Alcohol interaction. Good to know. Nursing care for phentolamine. Assessment.
Assessment. Check for contraindications, baseline CNS and CV status. Monitor urine output for kidney function.
Basics.
Potential nursing conclusions. Risk for injury. Altered cardiac output. Knowledge deficit. Planning. Therapeutic effect. Minimal side effects. Patient understanding.
And interventions for phentolamine.
Monitor heart rate and BP very closely, very frequently. Be ready to intervene if side effects are severe. If it's for extravasation, it's injected directly into the affected tissue.
Right into the site?
Yep. Provide supportive care for CNS effects like headache. Safety precautions for weakness or dizziness. Thorough teaching for patient and family. Offer support. Evaluation follows the usual path response, side effects, teaching effectiveness.
Got it. Okay, let's move to the selective alpha blockers. Alpha-1 selective adrenergic blocking agents. How are these different?
Right. Alpha-1 selective, these are more targeted. They have a much stronger preference for alpha-1 receptors compared to alpha-2.
More targeted. Does that mean fewer side effects sometimes?
Often, yes. Less of the broader sympathetic blockade you see with non-selective agents. Potentially fewer side effects like that reflex tachycardia we mentioned with phentolamine.
Okay. What are the key drugs in this alpha-1 selective group?
Main ones include alphazocin, doxazocin. Doxazosin's often the prototype drug here.
Doxazocin.
Prazosin, silodosin, tamsulosin, and terazosin.
Quite a few ending in osin.
That osin suffix is a good clue for many alpha-1 blockers, yes.
Good tip. So how do these work? their actions?
They selectively block those alpha-1 receptors on the postsynaptic smooth muscle cells. This reduces vascular tone, causes vasodilation, lowers blood pressure.
Lower BP, like the others.
Yes, but typically without causing that significant reflex tachycardia because they don't block alpha too much.
Less tachycardia. That's an advantage.
It can be. Plus, they also block alpha-1 receptors in the smooth muscle of the prostate gland, the bladder neck.
Ah, the BPH connection.
Exactly. This relaxes that smooth muscle, improving urine flow in men with benign prostatic hyperplasia, or BPH.
So, two main uses then, hypertension and BPH.
Primarily, yes. Doxazosine, prazosin, terazosin are used for hypertension and often for BPH symptoms too.
Okay.
Alfuzosin, silodosin, and tamsulosin are more specifically targeted for BPH. They hit a subtype of alpha-1 receptor found mainly in the prostate, so they're not typically first line for hypertension.
More prostate specific.
Got it.
Used alone or combined.
Can be used either way, alone or with other meds.
How about their pharmacokinetics, absorption, metabolism?
Generally well absorbed orally, they undergo pretty extensive metabolism in the liver,
Liver again?
and the byproducts are mostly excreted in the urine.
Okay. Contraindications and cautions for these alpha-1 selective guys.
Contraindicated with known allergy, naturally.
Yeah.
Also contraindicated during breastfeeding, as they can pass into milk.
Breastfeeding again.
Yep. Caution is needed with heart failure or kidney problems. The BP lowering could potentially worsen things. Same with liver impairment, since they're metabolized there. And caution during pregnancy due to potential fetal risks.
Standard cautions. What about side effects for alpha-1 blockers?
Side effects often stem from that vasodilation and sympathetic block. CNS, headache, dizziness, weakness, fatigue, drowsiness, sometimes depression.
Common CNS stuff.
GI nausea, vomiting, abdominal pain, diarrhea possible. Cardiovascular. Arrhythmias, hypotension, orthostatic hypotension is a big one here, especially with the first dose.
First dose effect.
Yes, that first dose phenomenon. Also edema, worsening heart failure, angina, flushing. The vasodilation can also cause nasal stuffiness, rhinitis, red eyes,
Nasal congestion.
and effects related to the GU system, especially with the BPH drugs like retrograde ejaculation and rarely priapism, that prolonged erection.
Priapism. Okay, that's serious.
Very serious. Needs immediate attention.
Drug interactions with alpha-1 blockers.
The main thing is additive hypotensive effects. Taking them with other drugs that lower BP or cause vasodilation, nitrates, calcium channel blockers, erectile dysfunction drugs like sildenafil, ACE inhibitors can really drop the pressure too much.
Watch for combined BP lowering. Makes sense. Nursing assessment for alpha-1 blockers.
Check for contraindications. Baseline alertness, vitals, CV and renal status. Check liver function tests.
Cover the basis.
Potential nursing conclusions, impaired comfort, risk for injury, especially falls from orthostatic hypertension, potential altered cardiac output, knowledge deficit, planning, therapeutic effect, minimal side effects, patient understanding.
And interventions for alpha-1 blockers.
Monitor BP and pulse regularly, especially checking for orthostatic changes. Implement safety precautions for falls.
Safety first.
Small, frequent meals might help with GI upset. Supportive care for CNS effects. Thorough teaching, especially about that first dose effect and getting up slowly. Offer support, evaluation, monitor response, side effects, teaching effectiveness, adherence, comfort.
Great. Okay, shifting gears again. Let's tackle the non-selective beta-adrenergic blocking agents. Beta blockers, how are these different from the alphas?
Right, beta blockers. As the name says, these block beta-adrenergic receptors. Specifically, the non-selective ones block both beta-1 and beta-2 receptors. They don't primarily target alpha receptors.
Block beta-1 and beta-2. Got it. What are the key non-selective beta blockers we should know?
There are quite a few. Think cardiolol, levobutanol, nadolol, nebivolol, propranolol is the classic prototype here.
Propranolol, the main one.
Sotalol and timolol. Many end in olol.
Another suffix clue. Olol for beta blockers. Good to remember. How do these non-selective beta blockers work? Their actions.
They competitively block beta receptors in the sympathetic nervous system. Blocking beta-1 receptors, which are mostly in the heart, leads to decreased heart rate, decreased contractility, less excitability.
Slows and weakens the heartbeat.
In a controlled way, yes. It also blocks beta-1 receptors in the kidney's juxtaglomerular apparatus, reducing renin release.
Less renin, lower BP. We saw that before.
Exactly. So that contributes to lowering blood pressure. Blocking beta-2 receptors, though, which are in the lungs and elsewhere, can cause bronchoconstriction. That's the downside for some patients.
The potential breathing issue.
Right. That's why selectivity matters sometimes.
So what are these non-selective ones used for? Indications?
Wide range. Many are used for hypertension, angina, preventing reinfarction after an MI.
CV staples.
Yes. So sotalol also acts as an antiarrhythmic for serious ventricular arrhythmias and maintaining normal rhythm in AFib or flutter.
Sotalol for arrhythmia.
Propranolol has a ton of uses beyond just BP and angina migraine prevention, stage fright, essential tremors, certain arrhythmias, adjunct in pheochromocytoma, even infantile hemangioma in that special oral solution.
Propranolol is really versatile.
Very. Nebivolol is primarily for hypertension, and timolol, cardiolol, levobunolol come as eye drops for glaucoma.
Glaucoma eye drops. Okay. Pharmacokinetics for these. Absorption, crossing the blood-brain barrier.
Oral forms are absorbed from the GI tract, metabolized by the liver. Food actually increases propranolol's bioavailability, but not usually the others. Sotalol absorption is decreased with food.
Food interactions, interesting.
Propranolol crosses the blood-brain barrier readily, which explains why it can have more CNS side effects. Nadolol and sotalol don't cross as easily.
Less CNS effects with those, potentially?
Potentially, yes.
Yeah.
They're all excreted mainly in the urine. The ophthalmic forms, the eye drops, have minimal systemic absorption if used correctly.
Okay. Contraindications for non-selective beta blockers, when to avoid.
Usual allergy, also bradycardia, heart blocks, shock, worsening heart failure.
Similar CV reasons as others.
Yes, and critically, because they block beta-2, avoid an asthma or acute bronchospasm, they can trigger severe breathing difficulty.
The asthma contraindication is key.
Absolutely key. Generally avoided in pregnancy due to potential teratogenicity, except maybe sotalol in specific cases, and during lactation due to effects on the infant.
Net cautions.
Caution in diabetes, again, masking hypoglycemia signs. Caution in COPD or asthma history, even if not acute. Caution with renal or hepatic dysfunction. Safety in kids often not established.
Okay. Side effects of non-selective beta blockers. What should we watch for?
Again, broad effects due to blocking both beta types. CNS, headache, fatigue, dizziness, depression, sleep issues, memory loss, confusion, especially with those that cross the blood-brain barrier like propranolol.
CNS effects from brain entry.
Right. CV, bradycardia, heart block, worsening heart failure, hypotension, poor peripheral circulation, cold hands and feet sometimes.
Cold extremities.
Pulmonary, difficulty breathing, cough, bronchospasm, pulmonary edema. This is the beta-2 effect.
The lung issue again.
GI upset, nausea, vomiting, diarrhea, stomach pain, GU, decreased libido, impotence, urinary issues. Also, decreased exercise tolerance, hyperglycemia, liver enzyme changes.
Lots of possibilities.
And again, never stop abruptly after long-term use. Same rebound risk. Severe angina, MI, hypertension, stroke.
Got it. Drug interactions for non-selective beta blockers.
Several important ones. With calcium channel blockers like verapamil diltiazem, increased risk of excessive cardiac depression. Additive effects with other antihypertensives.
Okay.
Stopping clonidine abruptly while on a beta blocker can cause severe rebound hypertension. Taper the beta blocker first, then clonidine.
Specific sequencing there.
Very specific. NSAIDs can blunt the BP lowering effect. Epinephrine might cause initial hypertension followed by bradycardia. Ergot alkaloids risk peripheral ischemia. And interactions with insulin antidiabetics regarding glucose levels and masking symptoms.
Complex interactions. Nursing considerations for non-selective beta blockers.
Assessment. Check contraindications, especially asthma. Baseline cardiopulmonary status, labs. Nursing conclusions. Potentially decreased cardiac output, altered tissue perfusion, injury risk, activity intolerance, knowledge deficit, planning, therapeutic goal, minimal side effects, patient understanding.
Interventions.
Emphasize no abrupt stopping. Continuous monitoring for IV forms. Monitor BP, pulse, rhythm, cardiac output. Supportive care for CNS GI effects. Encourage gradual activity increases. Offer support, thorough teaching, evaluation, response, side effects, teaching, comfort, adherence.
Excellent. Okay, last category. Beta-1 selective adrenergic blocking agents. How are these different?
Beta-1 selective. The key word is selective. At usual therapeutic doses, these primarily block beta-1 receptors, mostly found in the heart.
Just the heart ones mainly?
Mainly, yes. They have less effect on the beta-2 receptors in the lungs and blood vessels.
So potentially safer for patients with lung issues.
Exactly. That's their main advantage. Less risk of causing bronchospasm compared to non-selective beta blockers. But important caveat, this selectivity can be lost at higher doses.
Dose-dependent selectivity. Good point. Key drugs in the beta-1 selective group.
Acebutolol, Atenolol is often the prototype here.
Tenolol, okay.
Pitaxolol, bisoprolol, esmol, and metoprolol. Again, mostly olol endings.
Oh, well, again, good pattern. How do these selective ones work? Actions.
They selectively block those beta-1 receptors in the heart. This decreases heart rate, contractility, excitability, and reduces renin release from the kidneys.
Similar heart and kidney effects to the non-selective ones.
Yes, the beta-1 mediated effects are similar. But because they don't usually block beta-2 receptors at lower doses, they generally don't interfere with sympathetic bronchodilation.
Preserve the airway opening.
Right, which makes them preferred for patients who smoke or have asthma, COPD, allergic rhinitis.
Okay. So main uses, hypertension, angina.
Yeah, hypertension, angina, some arrhythmias, similar CV uses.
Yeah.
Preferred if there's underlying lung disease. Atenolol is very widely used for hypertension.
Okay.
Pitaxolol comes as eye drops for glaucoma too. Esmolol is only used for rapid heart rate control like in SVTs.
Esmolol for fast rates.
And metoprolol is also used for MI prevention treatment and stable heart failure, especially the extended release form.
Metoprolol for MI and heart failure too. Got it. Kinetics for beta-1 selective.
Absorbed orally, except IV esmolol in the eye drops. Metoprolol's bioavailability increases with food, similar to propranolol.
Metoprolol with food.
Metabolized in the liver, excreted in urine, metoprolol crosses the blood-brain barrier more than acetylol or Adderall, so potentially more CNS effects with metoprolol.
Metoprolol and CNS effects.
Okay.
Contraindications for beta-1 selective, are they the same as non-selective?
Mostly similar. Allergy, sinus bradycardia, heart block, cardiogenic shock, decompensated heart failure, hypotension, lactation. The big difference is that asthma bronchospasm is not an absolute contraindication, but rather a caution.
Caution, not contraindication for asthma. That's key.
Yes, and still used with caution, as selectivity can be lost at higher doses. Also caution in diabetes, thyroid disease, pregnancy. Safety in kids, often not established.
Side effects for beta-1 selective. Less lung stuff.
Generally, yes. You can still see the CNS effects, headache, fatigue, dizziness, depression, and the CV effects, bradycardia, heart block, heart failure, hypotension.
Still CV risks.
Absolutely. GI upset is possible. GU effects like decreased libido can occur, but rhinitis, bronchospasm, dyspnea are less likely than with non-selective agents, though still possible, especially at high doses.
Less likely, but not impossible.
Right. And the warning about abrupt discontinuation still applies risk of severe hypertension, angina, MI, stroke.
Still need to taper. Okay. Drug interactions for beta-1 selective.
Quite a few overlaps. NSAIDs, rifampin, barbiturates can decrease their effect. Clonidine might increase the hypotensive effect. Epinephrine interaction, initial hypertension, then bradycardia, can still happen. Increased risk with IV lidocaine. Increased orthostatic hypotension risk with prazosin. Verapamil, cimetidine, thyroid meds like methimazole, propyltyrosol can increase beta blocker effects.
Lots to check. Nursing assessment for beta-1 selective.
Check contraindications. Remembering asthma is now a caution.
Yeah.
Baseline neuro, cardiac, pulmonary, abdominal status, urine output, labs.
Usual baseline checks.
Nursing conclusions. Similar potential issues: impaired comfort, altered cardiac output issue perfusion, injury risk, activity intolerance, knowledge deficit, planning, therapeutic goal, minimal side effects, patient understanding.
And interventions for beta-1 selective.
Again, emphasize no abrupt stopping. Consult physician about stopping before surgery, give metoprolol with food, continuous monitoring for IV forms like esmolol, supportive care for CNS GI effects, encourage gradual activity, offer support, education, evaluation, monitor response, side effects, teaching, comfort, adherence.
That covers all the categories. Quite a journey through adrenergic blockers.
It is a lot, but so important. So let's try to summarize the key takeaways. Adrenergic blocking agents basically counteract the sympathetic nervous system, right?
Right. They block those fight or flight signals.
And they do it by targeting specific receptors, alpha or beta. And within those, they can be non-selective, hitting multiple types, or selective, focusing on just one type, like alpha-1 or beta-1.
And which drug is used depends entirely on that selectivity and what we're trying to achieve: lower BP, fix an arrhythmia, help with BPH.
Exactly. The clinical use flows directly from the receptor specificity.
And for everyone listening, especially future nurses, really understanding these differences, the types, mechanisms, indications, contraindications, side effects, interactions, it's just non-negotiable for safe practice.
Absolutely essential. You'll be giving these medications, monitoring patients on them. This knowledge is foundational.
Couldn't agree more.
This deep dive hopefully gives you a really solid base.
Mm-hmm.
But, learning doesn't stop here. Continued study, clinical experience.
No.
That's how you truly master these complex meds.
Maybe look into specific case studies or dig deeper into the kinetics of a particular drug you see often.
Great suggestion. Always keep learning.
Okay, and that leads us to our final thought to leave you with. Thinking about this idea of receptor selectivity we saw here, how does that broader pharmacological concept allow for more targeted therapies, maybe with fewer side effects, across all sorts of diseases, not just cardiovascular ones?
Yeah. That principle of hitting the right target while avoiding others, it's fundamental to modern drug development. It's something definitely worth pondering as you continue your studies.
Absolutely. Thanks for taking this deep dive with us today.